Welcome to the first lecture in renal physiology, and today we want to talk about physiology of excretion, mechanisms of urine excretion. But before we will begin, let me remind you that all the lecture notes you can find in PhysioSS Facebook group on the files category. And if you will have any questions, feel free to ask in the same group. So, learning objectives includes functions of excretory organs. Today we will also discuss structure of the nephron and blood supply of kidney, mechanisms of urine formation, which includes glomerular filtration, tubular reabsorption, and secretion. We will also talk about final urine composition and methods of kidney examination, including clearance. And let me begin with a brief overview of excretory systems, which includes skin, excreting water, electrolytes, urea, respiratory system, lungs, excreting carbon dioxide and water vapors, the digestive system, excreting solids, undigested foods, wastes, water, and salts, liver as a part of the digestive system, which excretes through the bile toxins, bilirubin, waste products, and drugs. And last but not least, the urinary system, kidney, excreting lots of waste products, including urea and also excess of water, salts. Kidney ensures that excessive substances, toxins, and waste products are excreted in urine. Functions of kidney include regulation of water and electrolyte balance, excretion of metabolic wastes such as urea, uric acid, creatinine, the end products of hemoglobin breakdown, metabolites. Functions also include excretion of biologically active substances such as hormones and many other foreign substances, for example, drugs. And you need to know how fast the drugs are excreted in order to prescribe a dose that achieves the appropriate body levels. Next function, regulation of arterial blood pressure. It depends on kidney ability to maintain the sodium and water balance to achieve regulation of blood volume. Next one, regulation of RBC's production. I hope you do remember that kidneys produce erythropoietin and its production is stimulated by decreased oxygen levels. And kidney disease, they may result in decreased erythropoietin secretion, which will decrease the production of RBCs by the bone marrow and might lead to the anemia. Next function, regulation of acid-base balance, regulation of vitamin D production, and gluconeogenesis. Let me remind you the anatomy of kidneys. Kidney is a bean-shaped organ which lie in retroperitoneal cavity, and it has three main regions: cortex, the outermost layer; medulla, the central region; papilla, the innermost tip of inner medulla. And urine from each kidney drains into the ureter and is transported to the bladder for storage and elimination via the urethra. I'm not sure whether you know it or not, but kidneys, they have a higher blood flow than even the brain, liver, or the heart. So let me guide you through the blood supply of kidney. Although the kidneys constitute less than 0.5 of total body mass, they receive up to 25% of the resting cardiac output via the right and left renal arteries. And in adults, renal blood flow, which means the blood flowing through both kidneys, is about 1200 milliliters per minute, which is pretty large. And this blood flow will be maldistributed. Least of it goes to the renal papilla, and most of it goes to the renal cortex. And in kidneys, you can find primary and secondary capillary networks. Glomerular capillary network, primary capillary network. That's the network between afferent glomerular arteriole and efferent glomerular arteriole, which will create the high blood pressure, and it will favor the glomerular filtration. Peritubular capillary network, secondary network, made by branches of efferent glomerular arteriole, and that's the area of low blood pressure, and it favors tubular reabsorption. Blood is completely filtered at the renal glomeruli. All amount of blood which flows to kidney has to pass through the glomerular capillaries before entering the venous system. And renal arteries, since they arise directly from the aorta, that's the area of high pressure, and this is what will facilitate the high blood flow to the kidneys. And renal glomerular capillaries, they will form a high pressure area with the pressure about 60 to 70 millimeters of mercury, which is much more greater than any other capillary pressure elsewhere in the body. High pressure in capillaries is maintained because of the diameter of afferent arteriole is much more wider than the one of the efferent, and high capillary pressure favors glomerular filtration. Peritubular capillaries, as I've mentioned before, it will form a low pressure area with the pressure of about 8 to 10 millimeters of mercury, and this low pressure helps tubular reabsorption. Kidney, they have a perfect autoregulation of the renal blood flow, and blood flow to kidney could be measured by using plasma clearance of para-aminohippuric acid. So here you can see the blood supply of the kidney, which will begin with the renal artery and it ends up with the renal vein. And here you can see primary capillary network and secondary capillary network. In most organs, capillaries recombine to form the beginnings of the venous system, but the glomerular capillaries, instead of recombining to form another set of arterioles called the efferent arteriole. This slide, it explains why do we have renal blood flow maldistribution. As you can see, in the cortex, you will have all the glomeruli located, and that's the reason why renal cortex receives most of the blood flow. A second capillary network, called the peritubular capillaries. So each nephron has two arterioles and two sets of capillaries associated with it. The first one, the primary capillary system, is a high pressure capillary system which will arise from afferent arteriole, then glomerular capillaries, and then the efferent arteriole. And this high pressure, it favors filtration. And after passing through the efferent arteriole, the blood enters the peritubular capillary system, a secondary capillary network, which is a system of low pressure, which will favor reabsorption. And in juxtamedullary nephrons, instead of peritubular capillaries, you will have vasa recta. Structural and functional unit of the kidney is nephron. Kidneys, they have over 1 million nephrons composed of the following parts. You will have corpuscle and the tubular system. Renal corpuscle consists of glomerulus or glomerular capillaries and glomerular or Bowman's capsule, which is a double-wall epithelial cup surrounding the glomerulus, and renal tubular system, which includes proximal convoluted tubule, loop of Henle, distal convoluted tubule, which will empty into the collecting ducts. So let's have a closer look at the nephron structure. Here you can see the glomerulus. The blood enters through afferent arteriole, then you will have a glomerular capillary network, and then the blood will leave through efferent arteriole and the renal tubular system. Renal tubular system, it includes proximal tubule, loop of Henle, distal tubule, which will empty into the collecting ducts. So let's discuss the structure of the renal corpuscle. Here you have the Bowman's capsule, which will surround the capsular space. It consists of podocytes, which will cover the capillaries to form the visceral layer, and simple squamous cells from parietal layer of the capsule, and the glomerular capillaries, which will arise from the afferent arteriole. Then they will form a ball of capillaries before emptying into the efferent arteriole. And please note that the vascular system in the glomerulus is purely arterial. The next thing which deserves to be mentioned is the filtration barrier. In the renal corpuscle, it consists of three layers: the capillary endothelium of the glomerular capillaries, then goes rather thick basement membrane, and a single cell layer of the epithelial cell. And let me explain it to you in a simple words. The first layer of endothelial cells of the capillaries, it will be perforated, and it has lots of windows which are called fenestra, and it looks like a slice of a Swiss cheese. The middle layer, which is the capillary basement membrane, it's not actually the membrane in a sense of lipid bilayer membrane, but it's rather a gel-like acellular meshwork, which consists of glycoproteins and proteoglycans, which with a structure like a kitchen sponge. And the third layer consists of epithelial cells called podocytes that will have an unusual octopus-like structure. And here on the microphotograph you can see the three layers of the filtration membrane, and that's the octopus which I have mentioned before. So there are two types of nephrons. One is the cortical nephron or superficial nephron, and another one is the juxtamedullary nephron. Cortical nephrons or superficial nephrons. Renal corpuscles will be located in outer cortex, and loops of Henle lie mainly in the cortex as well. And flow of fluid through the cortical nephron will be as follows. From glomerular Bowman's capsule, it goes to the proximal convoluted tube, then into the descending limb of the loop of Henle, then ascending limb of the loop of Henle, and then finally distal convoluted tubule. And you have from 80 to 85 cortical nephrons. Juxtamedullary nephrons. We have from 15 to 20% of these nephrons, and for them renal corpuscle will be located close to the medulla, and these nephrons, they have long loops of Henle which will extend deep into the medulla, enabling excretion or dilution of dilute or concentrated urine. And the flow of fluid through the juxtamedullary nephron will be as follows. From glomerular capsule into the proximal convoluted tubule, then descending limb of the loop of Henle, while ascending limb will consist of thin and thick limb of the loop of Henle, and then finally into the distal convoluted tubule. So here you have the summary of differences between cortical and juxtamedullary nephron, which we have discussed before. And differences in their structures will determine the difference in their function as well. As we have mentioned, they will have different blood supply, peritubular capillaries for cortical and vasa recta for juxtamedullary. While cortical nephrons mainly responsible for the formation of urine, juxtamedullary nephrons will be responsible mainly for concentration of urine. Now, the process of urine formation, it includes three steps. The first one, filtration. That's the process by which water and solutes in the blood leave the vascular system through the filtration barrier and enter the Bowman space. Reabsorption is the process of moving substances from the lumen across the epithelial layer into the surrounding interstitium and then from the interstitium into the surrounding blood vessels. Secretion is the process of moving substances into the tubular lumen from the cytosol of epithelial cells that will form the walls of the nephron. And in short, filtration, that's when it's filtered into the PCT. Reabsorption out of the PCT back into the blood, and secretion from the blood directly into the PCT, for example, or bypassing the Bowman's capsule. So we have two words which look quite similar, secretion and excretion, but please do not confuse them. Secretion means secreting the substance into the tubules from the extracellular fluid from the blood into the tubules, and it might not necessarily live with the urine. Excretion is what lives in the urine to outside the body. Excretion means exit of the substance from the body, means you remove it from the body with the urine. Now let's discuss a few definitions which you need to know if you want to understand filtration. Glomerular filtration is the process by which substances enter the Bowman's capsule, and you need to know glomerular filtration rate, which is known as GFR. That's the amount of fluid moving into the Bowman's capsule per unit time. In adults, the GFR averages around 125 milliliters per minute, or 180 liters per day. Renal plasma flow is the amount of plasma flowing through the kidney per unit of time, usually per minute. So, filtration. The principle of filtration uses the pressure as the force which will cause movement of fluid and solutes through the membrane. And it's exactly the same in glomerular capillaries as in other capillaries elsewhere in the body. We have discussed these already in cardiovascular system in microcirculatory bed. And that's what is known as Starling's law of the capillaries. You should remember that high hydrostatic pressure at glomerular capillaries is due to the short and wide arteriole and low resistance to flow, and the long, narrow efferent arteriole, which provides high resistance. Net filtration pressure could be calculated as a sum of hydrostatic glomerular capillary pressure plus oncotic pressure of the Bowman's capsule minus the sum of hydrostatic pressure of Bowman's capsule plus oncotic pressure of the glomerular capillaries. But since virtually no proteins will be filtered, the oncotic pressure, colloidosmotic pressure of the Bowman's capsule is 0, and you can write this formula as follows. Hydrostatic pressure of glomerular capillary minus hydrostatic pressure of the Bowman's capsule and minus the oncotic pressure of the glomerular capillary. So as you can see, the hydrostatic pressure of glomerular capillary, that's the force which pushes the fluid out, so it favors filtration. And hydrostatic pressure of the Bowman's capsule and oncotic pressure or colloidosmotic pressure of the glomerular capillaries, these are two forces which will oppose the ultrafiltration. So there they are. And if you will use the values like these, the net filtration pressure will be approximately 15 millimeters of mercury. So to understand filtration, you need to know what are the factors which affect filtration, then what is filtered and what is not, and how much is filtered. So let's discuss these points. Factors affecting glomerular filtration. Changes of effective filtration pressure, which altogether will make the net filtration pressure. Then changes of filtration coefficient, That's the permeability coefficient and the glomerular filtration membrane area, and any changes in renal blood flow. So let's talk about regulation of filtration pressure. What will happen if we will change the diameter of afferent arteriole? If there will be constriction of afferent arteriole, which will decrease the blood flow into the glomerulus, which means glomerulocapillary blood pressure decreases, the net filtration pressure decreases as well, and GFR drops. If you will have vasodilation of afferent arteriole, which will increase the blood flow into the glomerulus, the glomerulocapillary blood pressure increases, and the net filtration pressure increases as well, which will lead to increase in GFR. What about efferent? If you will constrict the efferent arteriole, you will increase resistance downstream the glomerulus, which will increase the hydrostatic pressure of the glomerular capillary, and this will lead to increased GFR. And if you will have simultaneous constriction of the afferent and efferent arteriole, the final result might be a small increase, a small decrease, or no change, which depends on the extent of vasoconstriction. In this slide, you have a summary of main GFR determinants and factors which influence them. So the first one you have is the coefficient, which is determined by glomerular surface area. For example, because of the relaxation of glomerular mesangial cells, the surface area increases, the GFR increases as well. Hydrostatic glomerular pressure, we discussed that. Increased renal arterial pressure, dilation of afferent arteriole, or constriction of efferent arteriole, which will increase resistance, will lead to increased GFR. Hydrostatic pressure of Bowman's capsule, if it increases, for example, intratubular pressure rise because of the obstruction of the tubule or extrarenal urinary system, will result in decreased GFR because this force, it opposes filtration. Now, oncotic pressure of the glomerular capillary or colloid osmotic pressure. If it will decrease, and that's the force which opposes filtration, then the GFR increases. Now, filtration membrane, what's the functional significance of this structure? It is that it permits the filtration of large volumes of fluid from the capillaries into the Bowman space, but it restricts filtration of blood-formed elements and large plasma proteins, such as albumins. And the selectivity of the barrier to filtrated solutes is based on both molecular size and electrical charge. And for any given size, negatively charged macromolecules are filtered to a lesser extent and positively charged molecules to a larger extent than the neutral molecules. Now, if a substance is freely filtered, does this mean that all of it will be filtered? No, it's not. Substances that are present in the filtrate are at the same concentration as found in the plasma, and that's what is meant, they are freely filtered. So please note that freely filtered does not mean all filtered. The amount of filtered substance is in exact proportion to the filtration to the fraction of the plasma volume that is filtered. So let's take a look at substances that are freely filtered. Major electrolytes, like for example sodium chloride, potassium bicarbonates, and so on. Metabolic waste products like urea, creatinine, metabolites. Glucose amino acids, organic acids, non-natural substances like inulin, para-aminohippuric acid, lower weight proteins, peptides like insulin, ADH, myoglobin. So the list looks like very long. And it's much more easier to remember what is not freely filtered. Substances like albumins and other plasma proteins, they are not freely filtered, as well as lipid-soluble substances that are transported in the plasma attached to proteins, like lipid-soluble bilirubin, thyroxine, and other lipid-soluble hormones, lipid-soluble vitamins. The next step is reabsorption. Kidney reabsorb and redistribute 99% of the blood volume, and only 0.1% of the blood filtered becomes urine. So here you have a summary of substances that are filtered, then how much will be reabsorbed, and what will be finally excreted per day. For example, you can see, as we've mentioned, 180 liters will be filtered, but then almost all of it will be reabsorbed, and we excrete only from 1 to 2 liters of urine per day. Reabsorption routes, you have two types. Substances could be reabsorbed transcellular or paracellular route. Types of transport, they include passive, which does not require energy. It happens along the electrochemical gradient. And here you have diffusion, simple, facilitated, and osmosis. Lipid-soluble substances will diffuse directly through the lipid bilayer, and water-soluble through channels, which could be gated, ungated. Gated could be open and closed. While active transport, it requires energy, it happens against concentration gradient, and it requires a carrier protein, and it could be divided into primary and secondary. Another classification includes uniport, transport of a single substance, symport or co-transport two substances in same direction, antiport or counter-transport substances in opposite directions. Types of reabsorption could be divided into obligatory and facultative. Obligatory reabsorption, it occurs in proximal convoluted tubule. That is when the substance is obliged to be reabsorbed. It's a must. Facultative reabsorption, it occurs in collecting ducts, and it's under the control of hormones, and it depends on the concentration of a substance in the bloodstream. So DCT and collecting ducts, the facultative reabsorption, and obligatory in PCT. One more thing which we have to discuss is the renal threshold value. It's the level of a substance in its highest concentration in the blood up to which it is totally reabsorbed from the glomerular filtrate. And all of the substances could be divided into three categories. High threshold substances, those whose total amount may be reabsorbed actively. Examples include glucose, amino acids. Low threshold substances are reabsorbed only up to a small extent. Examples: urea, uric acid. And non-threshold substances that are not reabsorbed at all: creatinine and para-aminohippuric acid. Now, let's talk about transport maximum, and we will use glucose as an example. The normal blood glucose level tested while fasting for non-diabetic people should be between 3.3 and 5.5 millimole per liter, or 70 to 100 milligrams per deciliter. For those without diabetes and who are not fasting, it should be below 6.9 millimole per liter, or 125 milligrams per deciliter. And the relationship between plasma glucose concentration and the rate of glucose filtered, which is called filtered load, reabsorbed or excreted. So here you can see the dotted line. It shows the transport maximum, which is the maximum rate which glucose could be reabsorbed. And please notice that as plasma glucose exceeds its threshold, glucose begins to appear in urine. This will happen for glucose when its concentration in the plasma is about 10 millimole per liter. So at this value, all the carrier proteins will be saturated, which means no more glucose could be reabsorbed, and the excess of it will be excreted urine. Next thing which you have to recall is the size and, most importantly, the structure or type of epithelium which you have in the tubular system. Why is it important? Because the structure of it will determine the function. Like, for example, in PCT, you will have brush border epithelium with the microvilli, which will significantly increase the total surface area, and this will favor reabsorption. And in DCT, you will have such cells as principal cells and intercalated cells, which will help to that's the site of hormone action, because these cells, they will have receptors, and that's what determines their function. So we will discuss the reabsorption and the way it happens in different areas of the tubular system. And we will begin from the proximal convoluted tubules. As you can see, here you have large amount of water reabsorption with electrolytes, and 100% of glucose and amino acids will be reabsorbed in proximal convoluted tubule. And also, in addition, in proximal convoluted tubule, there will be a secretion of variable amount of hydrogen ions, ammonia, and urea. Let's talk about sodium reabsorption. Sodium reabsorption will happen by active transport, but there will be no transport maximum in this case. Basolateral ADPases establish a gradient across the tubular wall. Proximal tubule is very permeable to sodium, so ions flow down the concentration gradient across the membrane, and that's the passive type of transport. As I have mentioned, microvilli create a large surface area for the absorption. And there will be also electrical gradient created, which will draw the chloride ions across. And as you remember, sodium is highly hydrophilic, so water follows sodium due to the osmotic force, which means fluid left in the tubule will be concentrated. Now let's talk about glucose handling or glucose absorption. It also relies upon the sodium gradient, and all of the glucose will be absorbed in the proximal convoluted tubule. At the apical membrane, it requires a carrier protein, which is called sodium glucose cotransporter, or SGLT carrier protein. As you remember, sodium concentration in the cell is quite low, so sodium would like to enter into the cell, but it has to be accompanied by the glucose. So only when sodium and glucose will be attached to this carrier protein, these two together could be transported into the cell. And why do you have low concentration of sodium inside the cell? Is because of the activity of sodium potassium pump, which pumps out free sodium and pumps in potassium, and this requires energy. So this is primary active transport, and this is secondary active transport. And let me remind you, when plasma glucose concentration increases up to a value of about 180 to 100 milligrams per deciliter, then glucose can first be detected in urine, because all the carrier proteins will be saturated, and that's when you exceed the threshold. That is what is called renal glucose threshold. Amino acid handling is pretty much the same as the one for the glucose. It also requires sodium cotransport based on exactly same mechanisms. Now, potassium handling. Potassium is the major cation in cells, and its balance is essential for life because even the slightest changes will lead to hyperkalemia, which might cause ventricular fibrillation and then death. Because if concentration increases up to 3.5 millimoles per liter, cells will hyperpolarize, leads to arrhythmias and death. What we have, reabsorption of potassium at proximal convoluted tubule, and also we have excretion and potassium secretion in distal tubule, which is mediated by the hormone aldosterone. So once again, reabsorption at the proximal tubule, and it's mainly passive and follows the movement of sodium and fluids. Potassium secretion occurs in collecting tubule principal cells and relies upon the active transport of potassium. Now, reabsorption in the loop of Henle. In loop of Henle, you will have reabsorption of water and electrolytes. And loop of Henle, it sets the stage for independent regulation of both the volume and osmolarity of body fluids. Let me remind you the definition of osmolarity. Osmolarity is expressed in units of osmoles per kg of water, or sometimes commonly called osmotic pressure. Osmolarity and osmotic pressure have the same meaning. They are just expressed in different units. And osmotic pressure resulting from proteins only, ignoring everything else, is called the colloid osmotic pressure or oncotic pressure. We have mentioned it before when we were talking about net filtration pressure. And it's function of both the concentration of solutes and kind of solutes. And here you can see the different substances, they contribute in a different way to the colloid osmotic pressure and osmotic pressure. Now, in loop of Henle, you will have countercurrent, multiplier, and exchanger. What does that mean? A countercurrent system is a system of U-shaped tubules in which the flow of fluid is in opposite direction in two limbs of the U-shaped tube. So what's the role of loop of Henle in development of medullary gradient? Loop of Henle of juxtamedullary nephrons plays a major role as a countercurrent multiplier because loop of these nephrons is long and extends deep into the medulla. So the main reason for the hyperosmolarity of medullary interstitial fluid is the active reabsorption of sodium chloride and other solutes from ascending limb of loop of Henle into the medullary interstitium. So you can see here there is a gradient progressively increasing up to the hairpin of the loop of Henle. And these solutes, they accumulate in the medullary interstitium and increase its osmolarity. Apart from these, there is regular addition of more and more new sodium and chloride ions into the descending limb by constant filtration. Thus, the reabsorption of sodium chloride from ascending limb and addition of new chloride from the filtrate increase or multiply the osmolarity of medullary interstitial fluid and medullary gradient. Hence, it is called countercurrent multiplier. We also have vasa recta. Vasa recta, they act as countercurrent exchanger because of its position. It is also U-shaped, as you can see, with descending limb, hairpin band, and the ascending limb. And vasa recta runs in parallel to the loop of Henle, and its descending limb runs along with the ascending limb of the loop of Henle. Sodium chloride reabsorbed from ascending limb of Henle enters the medullary interstitium, and from here it enters the descending limb of vasa recta. Simultaneously, water diffuses from descending limb of vasa recta into the medullary interstitium. So the blood flows very slowly through vasa recta. And so a large quantity of sodium chloride accumulates in the descending limb of vasa recta and flows slowly towards the ascending limb. By the time the blood reaches the ascending limb of vasa recta, the concentration of sodium chloride increases very much. This causes diffusion of sodium chloride into the medullary interstitium, and simultaneously water from medullary interstitium enters the ascending limb of vasa recta, and the cycle will be repeated. That is why it's called countercurrent exchanger. And recycling of urea also occurs through vasa recta. So the final concentration of urine will be achieved by the action of ADH. Normally, the distal convoluted tubule and collecting ducts are not permeable to water, but the presence of ADH makes them permeable, resulting in water reabsorption. And water reabsorption induced by ADH is called facultative reabsorption of water. And a large quantity of water will be removed from the fluid passing through the DCT and collecting ducts. And so the urine becomes hypertonic with an osmolarity of about 1200 milliosm per liter. Once again, the descending limb of loop of Henle is permeable water, will be reabsorbed, and ascending limb is permeable to sodium chloride. So isotonic urine enters the descending limb, and since the osmotic gradient increases, water will be reabsorbed. So here in the hairpin of the loop of Henle, you have highly concentrated urine, which enters the ascending limb. And due to the gradient, now the sodium will be reabsorbed, which helps to maintain the gradient. And in DCT and collecting ducts, that's the action of ADH, which will cause reabsorption of water. As a result, you will excrete small amounts of highly concentrated urine. So here you have the cartoon animation which shows how it works. So a brief overview. In a countercurrent mechanism, you can have urinary concentration or urinary dilution, depending on concentration of water in the body. So the basic requirements for forming a concentrated urine will provide high levels of ADH and a high osmolarity of the renal medullary interstitial fluid. And countercurrent theory, it consists of countercurrent multiplier, the Henle's loop, and countercurrent exchanger, the vasa recta. And to summarize renal handling of urea, urea is freely filtered. About half is reabsorbed in the proximal convoluted tubule, and amount equal to the reabsorbed is then secreted back into the loop of Henle. And finally, about half is reabsorbed again in the medullary collecting duct. The net result is that about half of the filtered load is excreted. Now, reabsorption in the distal convoluted tubule, you have reabsorption of water and electrolytes. And once again, let me remind you that reabsorption here is called facultative. And here you have the principal cells which help to reabsorb sodium and secrete potassium under the action of aldosterone, and the intercalated cells which will provide the secretion of hydrogen to maintain pH. Tubular secretion summary. That's the transfer of materials from the blood into the tubular system. Secreted substances include hydrogen ions, potassium, ammonia, creatinine, and some drugs. Tubular secretion has two important outcomes. The secretion of hydrogen helps to control blood pH, and secretion of other substances helps to eliminate them from the body. On this slide, you have a summary of the events which occur in each of the parts of the nephron, like proximal convoluted tubule, which substances could be reabsorbed and secreted. Then the loop of Henle, the countercurrent mechanism, then the distal convoluted tubule, and the collecting ducts with the principal cells. And in renal corpuscle, you have glomerular filtration. Now, let's talk about composition of the urine. Urine contains about 4% of solids, which includes non-organic substances like water and electrolytes, protein-origin urea, that's the main product of protein breakdown, uric acid, ammonia, creatinine, non-protein origin substances like salts, acids, and pigments. Normal urine volume might vary depending on your water intake, but usually it's 1 to 2 liters per day. Color is a straw yellow. Then it should be transparent. pH fluctuates widely, and it varies considerably with the diet. Like high protein diet will increase the acidity, and vegetarian diet, that's what make the urine more alkaline. Specific gravity also varies within the wide range, and it depends on the concentration of substances. And here you can see a brief overview on pathological findings which could be present in urine. You remember that albumins should be absent because under normal conditions, filtration membrane is not permeable to large molecular weight proteins, which means if they appear in urine, which is called proteinuria, the filtration membrane is damaged. Glucose also should be absent in final urine because it must be completely reabsorbed. And you remember that the transport maximum is around 10 millimole per liter. That's when carrier proteins will get saturated, and the excess of glucose will appear in urine, which is called glycosuria, and that could be the sign of the diabetes mellitus, as well as presence of ketone bodies. Formed elements should be also absent because they are not filtrated the filtration barrier. And if RBCs are present in urine, that's what is called hematuria. Also in final urine, no microbes should be present. How to evaluate function of the kidneys? You can use urine analysis, blood tests like blood urea nitrogen, plasma creatinine, because the main function of the kidney is the excretion of waste products, and renal plasma clearance. Clearance, what is that? It's reading the body of a substance. When the substance is removed from the body, from the blood, and excreted into the urine. So clearance is defined as the volume of arterial plasma required to produce the amount of substance X excreted in the urine per minute. Units are volume per time, not amount per time. And it's critical to evaluate the renal function. Here you have the clearance formula, and clearance of substances with specific properties provides the understanding and determination of GFR, glomerular filtration rate, and renal blood flow. So the formula of the clearance, you have concentration of a substance X in urine multiplied by the volume of urine per unit time and divided by the concentration of substance X in plasma, which will give you the clearance or the volume of plasma clearance of a substance X per unit time. Clearance is used to determine glomerular filtration rate. In this case, you can use inulin as a substance. That's the polysaccharide starch, and it's freely filtered by the glomerulus, but is not reabsorbed or secreted by the nephron. All the inulin that is filtered flows through the nephron and appears in urine. Therefore, the volume of plasma cleared per unit time is the same as glomerular filtration rate, because no reabsorption of inulin and no secretion of inulin. The next substance which you can use is para-aminohippuric acid. It's a small molecular weight, water-soluble organic anion. It is freely filtered and also secreted by the proximal tubule epithelium, and its clearance therefore is nearly as great as the renal plasma flow. In fact, the paraminohippuric clearance is used as a measure of renal plasma flow and is usually called the effective renal plasma flow. To indicate its value, it's slightly less than the true renal plasma flow. So once again, to determine GFR, you can use inulin, which is not naturally present in the body. Instead, you can use creatinine, which is normally present in the blood, and it's not reabsorbed and minimally secreted by the kidney. So you can use it to calculate the GFR. And paraminohippuric acid clearance is equal to the renal plasma flow, because this substance is removed from the blood by the kidney through combination of filtration and secretion. Thank you for your attention.